All right, well, let's go ahead and get started. Good afternoon, everyone. Good morning, good evening to you, wherever in the world you are today. My name is Arik Shimmick, and I have the pleasure of joining you today with Dr. Lovey Reynolds to host our first session here in the advocacy piece, or the advocacy arm of the Center for Global Pediatric Health, called Local Hands and Global Impact. So thank you for joining us today. For those of you who are relatively new to the center, to explain a little bit about who we are and what we do. We are an interprofessional collaboration between the Northwestern University's Feinberg School of Medicine and the Anna Robert H. Lurie Children's Hospital of Chicago. We have three main pillars, including advocacy, education, and research. And our mission is really to build a community of faculty and trainees dedicated to helping grow and really solve some of the greatest global health challenges for children here in Chicago and around the world. I put at the bottom of this first slide just how we define global. I want to kind of start with that here in our conversation today, because I think when I first shared my definition of global with a colleague, she pushed back on it. And I said, well, to me, in my education, global meant somewhere else, right? We had to go do global health somewhere else. We had to go do something that wasn't in my hometown. And she pushed back and said, that's kind of a very Western way of thinking about it. I said, well, I would agree with you. That has been my experience as someone who is trained here in the United States and working in Chicago, Illinois. So I should mention that I am a practicing clinician as well as a registered nurse here in our CCU. And I think that combination of clinical care expertise and this passion for advocacy is what has led me to the center. So very happy to have you with us. We'll go ahead and get started here with our discussion. First, about the social determinants of health. We understand today that everyone coming to this conversation is coming in with varying levels of education or experience with these topics. So we wanted to just start with a level setting about what we're talking about when we talk about the social determinants. The social determinants of health come down to these things that really affect our health based on where we live, where we go to school, where we work, where we play, and falls into these five main buckets of education, health, healthcare, our neighborhood or built environment, the social and community context, and the economic stability of where we are. So going through that first bucket, when we think about education, this is especially important for those of us in healthcare, right? We think about the health literacy of our patients. We think about the educations that we had to go through to become clinicians or providers of healthcare. But when we think about how people access and understand what's happening to them and to their bodies, we need to remember that education plays a huge role both in one's ability to afford healthcare, but also in their ability to understand it. So when we think about health and healthcare, then we always need to think about the structure and the staff and the systems, right? So things need to be in place for us to have a healthcare system for people to go to when they're sick or when they need preventative care. This can include everything from the preventative primary world all the way through how do we pay for it, right? Is it universal health coverage? Is it private insurance? Perhaps a blend of both. And again, health literacy, right? How are we preparing people to be consumers of their own healthcare and their own healthcare education? Many of us, when we understand the social determinants, naturally kind of think first of some of the topics we've been most exposed to. Some of those things include things like safety. What does your neighborhood look like? Crime and prevention of violence. And certainly coming to, here in Chicago, a major metropolitan city in the United States, we have some of those challenges day in and day out. So we've felt that, we've seen firsthand the outcomes of violence and crime in our pediatric populations. But we also need to think about the quality of housing, where people live, how far are they from the system of healthcare that they want to access, and thinking about transportation. How far do we need to go to get healthy food, for example? So when we look at a city like Chicago, we think about healthcare and the food deserts, right? Is your closest point of purchasing food going to be more of a convenience store type setting, or is there perhaps a community garden that you could access fresh fruits and vegetables? In our social and community context, my spouse and I like to watch a lot of the shows about the blue zones in the world where we talk about what it takes to become someone who lives to be over 100, right? What are the pieces of that lifestyle that really benefit people in the community? I think is one that comes up every time in every one of those shows. We think about somebody's sense of belonging. How do they feel in their own environment? Do they have a chance to participate, right? Are they able to cast a vote, for example? Or do they feel discriminated against? Are they a marginalized community in an area that's not their natural home or their historical home? So all of these things come into play when we think about how does someone feel about the space where they exist each and every day. Last but not least, unfortunately, in the world of everything these days, you can't talk about anything anymore without talking about the money. So do we have the money to be able to pay for the things that we need? Or are we asking patients, parents, families to make decisions between getting a medication filled or putting food on the table that night? Is there poverty or a history of poverty in the family? Are they experiencing housing instability? What do all of these things mean in the context of our patients' lives? And how does that come through in the outcomes and maybe the inequities that they experience? So many of you who have some familiarity with this topic may not need these next couple of slides, but anyone who's new, I just wanted to highlight a couple of key points that really underscore why these matter in our practice. And our conversation today is to help build that connection for you between the social determinants and what's happening at the United Nations level. So in the social determinants, when we look at things like some of these quotes are amazing, right? 80 to 90% of health outcomes are determined by the social, environmental, and behavioral factors of our patients and families, not necessarily the care itself or the genetics that they were given at birth. People living in low neighborhoods or low income areas of a city can have a life expectancy of up to 20 years less than others. And when we think about the fact that a lot of our repeat customers, right, the frequent flyers that come back time and time again, up to 60% of those visits could have been avoided if we had proper preventative care or if we had made the investments in the social systems that people live in. And for us as healthcare workers, and again, I'm going to use that as a very broad term because I do want to be inclusive of every single person in healthcare. Whether you're a nurse like myself, a physician like some of us here in the room, whether you're in hospital operations, food service, environmental, security, every single person in the healthcare system has a role here. And I want everyone to feel very included in this topic because it does matter for all of us. But when we think specifically about those of us who are employed in this sphere, it's relevant to our practice because as you can see, the majority of people feel that unmet social needs lead directly to poorer outcomes, but not many of us feel empowered or connected with ways to improve them. The second bullet point I put in there as kind of a yay moment, but also then when I read it again the second time, it turned into kind of a negative. I said, 1 out of 4 US hospitals now screens for social determinants of health. But why is it only 1 in 4? 25%, that means 75% of US hospitals are not doing enough on this topic. And lastly, because we are an interprofessional group, I'd love to just call out the fact that it's not just researchers or physicians or CNOs or hospital leaders who have responsibility for this. Everybody gets exposed to these things. And that last bullet point talking about allied health professionals, people like nurses who spend time with patients and families have such a good insight into what's going on with that patient and family that I think it's really important to make sure they're connected to these kinds of conversations. Well, let's bring it home here to Chicago again. This is where the center is based, and I love to use these examples when I give this talk because it's often easy to ignore problems that seem distant or far away. Here in Chicago, we have a huge gap in our life expectancy, unfortunately. Downtown here in Chicago in the Loop, we have a life expectancy of 87.3 years, and less than 10 miles to our west, it drops down to 66.6. It is a 20-year gap in 10 miles. And now you may say, well, wait, Arik, it's a huge city. There's a lot of different kinds of people, right? It's a true melting pot. Maybe there's room for some variation. And I get that. I don't accept the variation that we have. So when you drill down to some of the neighborhood differences, for example, here on the south side, that middle graphic is talking about the difference between 2 different parks on the south side of Chicago. Hyde Park, where the University of Chicago is based, has a life expectancy of 82.6 years. If you cross the street and go into Washington Park, it drops by 10 years. So this is not a question of a city of millions of people is going to have a large variation. This literally happens from neighborhood to neighborhood. One of my other favorite examples here in Chicago is talking about tree canopy. As we talk a little bit later about climate change and what's happening in the world around us from a physical standpoint, there are areas in Chicago that have fewer trees than others. And when you look at where the wealth distribution and the education distribution lives, you can see that there are areas in Chicago where a heat wave is going to have a much higher impact than in others. So whether you are someone calling in virtually joining us today from another country, another part of the world, or you're a clinician here in Chicago, these types of inequities exist everywhere. And whether this is an example for you to use or one for you to just kind of accept as proof that this is an important topic, we wanted to just highlight some of these options for you so that you have a better understanding. Now, I always joke that if I ever won an award like a Grammy or an Oscar or something, I know I would forget to thank someone. So I cannot have a conversation or start this conversation with you without acknowledging that this is a topic that is being worked on by many groups in many parts of the world. Here in Chicago, the Chicago Department of Public Health, in their the action plan, which I, of course, forget the name of as I'm speaking here, but CDPH is working on this topic. And I also wanted to highlight that here at Lurie Children's, our most recent community health needs assessment does an amazing job of diving into these issues that we face locally. So whatever context or resource or area that you're in, use your local assets to make sure that whatever conversations you're having or research you're doing has a cultural and a local context to it. So that is my way of saying I have won an award. I forgot to thank everyone, but thank you very much to those two on the screen who are doing this work. Last but not least, kind of under our topic of Chicago, I do like to always talk about O'Hare for many different reasons. When we were first thinking kind of back in the post 9/11 days, we talked a lot about Chicago O'Hare as an airport and what that meant for safety and security and tourism. We looked at numbers of flights every day because we thought that was a better way for us to assess our risk. And that kind of shifted a little bit as the times did, right? We started thinking about things like the Ebola outbreak or different pandemics, for example. When you think of how many people come and go through an airport like Chicago O'Hare, you can see that each and every day we have about 135 international landings per day. Well, what does this mean, right? This is important, yes, for safety and security, and certainly important in the world of communicable disease. But I want to drive home the point here that this is also an issue for non-communicable diseases and things like the social determinants of health. The disparities that are created by us ignoring the social determinants come with our visitors each and every day. They show up in our emergency rooms, they go to our urgent cares, they come with students who are here to study, they come with families who are here as refugees. You don't have to go anywhere else other than where you are to witness the damage caused by ignoring the social determinants. Well, let's talk a little bit about the United Nations here. I would love to give a full class on this because it is quite a lot of detail and understanding to go through. But for those of you, like I said, who are maybe new to the conversation, the UN is the world's largest collaboration effort. It is 193 member states that have come together to really try to tackle the things that not one nation state can do by themselves. This was founded after the Second World War, when the League of Nations as a group was unable to keep us from going into that World War. So when World War II ended in 1945, the United Nations was formed as a way to really make sure that first and foremost, the world was going to be safe and we were going to have peace. In addition to that, there was a pretty clear understanding that in order to prevent war, we need to make sure that people have recognized and respected human rights, and that we had development that protected and prioritized every single person around the world. We can't have peace and security with things like poverty and hunger and inequality. So the UN, based in New York, Geneva, Nairobi, and Vienna, they have 4 headquarters. It is truly where the world comes together, and every single nation state has the same vote. It's a spot for us to hold each other accountable. It's a spot for us to partner and to work with each other on the things that, like I said, not everything can be handled at a national or a local level. It is really, really important to understand this basis as we go into the next couple of slides here. On that note, I would like to wish everyone a happy United Nations Day, October 24th. This is the reason that we chose this day as our presentation day. It is UN Day, and what that means is in October 24th, 1945 is when the UN came into being, and its charter was officially approved, ratified, and moved into effect. I love showing this slide, not because there's a test at the end of this presentation, but I do like to show people just how chaotic and disorganized the UN system at a high level can look and feel. On the left, you have 6 principal organs of the UN family, from the General Assembly down through the Security Council. You probably have heard about some of these on the news, right? These are the people that make the news and make the decisions of what the UN is going to tackle. But within that, you've got a lot of other groups. You have funds, entities, programs, regional councils. You've got a spot for civil society. All of this comes together to make this very confusing cloud of work. And part of what I love about the United Nations is that it is, again, a space that is for global negotiation and cooperation. There's nothing else like it in the world. What I don't always appreciate is that something that big cannot move quickly. It is very difficult for us, and by us, I mean us as civil society people, to participate in this system, right? The 193 member states have permanent groups of people like ambassadors that do this on behalf of each country's government. There is a spot for civil society, which we'll touch on later, but just know that as you are interested or thinking about ways that you can participate, it's going to look a little confusing at first. There's a lot of stuff going on. And on the next slide, I break down a little bit more of just who these primary organs are. Again, this may be very high level or a little bit too much detail for the interests that you have related to social determinants. But when we think about how global cooperation can tackle inequity, we need to understand who the decision makers are. So we're going to talk about the top 2 first. The UN General Assembly meets every September in New York. So if anyone is joining us virtually from New York, I apologize every year that we typically shut down New York Midtown for about 2 weeks each September as 193 member states and their heads of state come together to talk about what comes next. Decision making is done by a 1-vote cast system, so everybody in the room has the same vote and the same weight. And this is very different from the Security Council. Thinking back to what we know about why the UN exists, right? The Security Council is there to protect security, and they're actually the really only arm of the United Nations that has a true legally binding power. So I won't go through too much of this next slide, but just know that it's all focused on cooperation and collaboration, and that to me sounds very much like healthcare and what we do every day. Quick example of just some of the other agencies or specialties that you may have heard of, like the WHO, the World Health Organization. There's funds and programs like UNICEF, and there's also peacekeeping operations like MINUSTA, which was the peacekeeping mission in Haiti. So all of these areas are opportunities for us to get involved and to work with the programs and the funds doing the work of. So how do we do this, right? How do we dictate, or how do we figure out what's important and where do we go first? So from 2000 to 2015, the UN had something called the Millennium Development Goals. They were very much focused on basic human needs, right? Rooted in this idea of moral urgency, like everybody has the same right to health and happiness. It was driven by measurable outcomes. They had a couple of targets, and we all kind of knew what we were supposed to work on to achieve them. When those expired in 2015, the UN ratified what is called the 2030 Agenda for Sustainable Development, or also known as the SDGs. These go through 2030, and they're a little bit different, right? You can see just from the graphics, there's definitely more of them. So instead of 8 goals, we now have 17. But the SDGs are more of a root cause focus. They want to drill deeper into why are the inequities happening in the first place. And in these 17 goals, we have 169 different targets that help us as nations cooperate to make good progress. The SDGs have a wider reach. They cover a lot more topics than the MDGs did, and they're universal. That was a big shift for us, going from, hey, these are the 8 targets for developing nations to focus their efforts on. And I didn't mention there, the bottom bullet point, the top-down global framework in the MDGs was really focused on kind of NGO leadership in achieving these, okay? Universality now of the SDGs is saying that every nation has a responsibility to focus on these, whether you are considered a high-income country or a developing nation. Every single person has a spot, and we should be focusing on local leadership and not NGOs. Also, the SDGs are much more climate aware, and we're going to talk about that in our next couple of slides, but realizing that climate change is happening. I'm not going to go into the reasons that people say that it is, but we are experiencing changes to our weather and to our weather systems. Now, as you can imagine, excuse me, we were on track quite a bit with some good stuff up through 2020 when we experienced the COVID-19 pandemic. This is from the most recent report, the 2025 Sustainable Development Report. And unfortunately, 35% of the SDGs are on track or making moderate progress. Only 35%. The green and the yellow there on the left. 48% of our SDGs and their targets are stalled. Unfortunately, even worse, another 18% have gone back to levels below 2015. So we've gone backwards on 20% of the work we set out for ourselves. If you're interested in this, there is a ton of data out there. And as we talk about the SDGs and how they connect with the social determinants, do know there's some great resources. We have included 2 here for you, including the report that I just mentioned, as well as this dashboard website on the right. I use this quite a bit when I'm trying to get an idea of how to approach someone who may be a representative from another country, or maybe they work for an organization that works in a region I've never been to or I'm not familiar with. You can drill down to country level specifics on each of the SDGs. So if you're passionate or you're working on things like clean water, which is SDG number 6, you can see where it's going well, where it's struggling a little bit. And more importantly, get an idea of who are the actors involved in that work to better help focus your advocacy efforts. So now when we look at the SDGs, I want to just point out that perspective does matter, right? In the hub and spoke model on the left, we have SDG number 3, which is good health and well-being, very much at the center of things. And I think as clinicians or healthcare operatives, we're pretty comfortable with that, right? We see healthcare as both an input and an output. So we understand that nothing can exist without health, and without everything existing, we will never have good health and well-being. But based on your interests, whether they're academic, research, advocacy focused, you could also think about the SDGs by different themes, right? People, planet, peace, prosperity. You can break them down into different groups. But where I really enjoy is this next slide. And I talked through this a few different times, and I think the way that it makes most sense in my mind to look at the linear model almost from the right to the left. So this model was built by a group in Australia, and it does try to align the size of the box and its linear connection to how people experience or report feeling good health and well-being. So if you're thinking about outcomes on the right-hand side there, right, we want the outcome of good health. We want the outcome of reduced inequities. And if you go a little bit to the left to that column that says highest priority, the downstream determinants, these are things that I think a lot of us clearly connect with good health and well-being, right? Poverty, hunger, clean water. Certainly in healthcare, we understand the detriment that comes with not having clean drinking water or sanitation. But when we look at where we can really get involved and where we can put this idea of health and all policies into play, the upstream social determinants, the next column to the left again, is going to talk about things like SDG 11, which is sustainable cities, good education, number 4, responsible consumption, number 12. All of this is based on the fact, though, on the far left there, that we need a healthy and happy planet to function on in the first place. If that didn't do it for you, if that didn't connect it, I also like the hierarchical model, which is thinking kind of up, down, or the wedding cake model, if you will. So if you put at the basis, right, we need a happy, healthy planet for us to live on. Then we need happy, successful societies. We need good economies. And on top of that, we are having partnership with the goals throughout everything. So you can see no matter where your interest lies, you can kind of look at the SDGs from different perspectives and see how different things connect and group with each other. But where we're going with this is the WHO traditionally has put out a list of their top 10 global health threats each year. They haven't done it for a few years, but we did a scan of this recent article, which is hyperlinked there, It's basically them showing or warning of slowing global health gains in their new statistics report. I took the liberty of highlighting for you everything in red that touches the social determinants of health. I'll go ahead and give you a moment to look at that. You probably have noticed everything is highlighted in red. Everything the WHO is nervous about has a basis or has a place for action on the social determinants of health. On the right-hand side, if you're interested in connecting those two a step further, we've included some of the specific SDGs and targets that go with each of those. Calling out their World Statistics Report too, I wanted to highlight just these 5 different areas where both the social determinants and the SDGs come together. When we talk again about money, right? We're looking at the entire world now. This is how are we as a planet doing? 193 member nations. You can only imagine the variation you see between countries. So whether you're interested in talking about the healthcare workforce, things like childhood immunization, gender inequality, or access to universal healthcare, all of these have huge data points behind them that link both to the social determinants, but also show up when we go to the United Nations level and talk about the SDGs and why this matters for healthcare workers. I'm going to wrap up here very quickly, and I promise we will share these slides, and if there's a lot of content on here, if you're interested in coming back to it. But when we think about some of the environmental determinants of health, I wanted to highlight again homes and communities on this list, because according to the United Nations, by 2030, almost 70% of the world's population is going to live in an urban setting. That's huge. So when we think about homes and communities, we have to talk about quality building supplies, right? How is your health altered or an outcome really of the space that you live in, whether it's mold, asbestos, asthma, things like that. We also now need to start talking more about things like how do the homes we build today sustain or withstand natural disasters. It's no secret that here in the United States, the majority of our data centers are in the deserts of the Southwest because they have the fewest weather-related incidents. So if you're on the western coast or the eastern coast, you may be worried about earthquakes, hurricanes, typhoons. Here in the Midwest, we talk a lot about blizzards and tornadoes. All of these things have a risk factor associated to them when we think about, is your home going to be standing after a natural disaster? If not, what does that do to your health? So again, connection here for you to some of the SDGs on these slides. And on the next one, a little bit more of a bigger picture one, I highlighted too, again, crime and violence is a huge issue for our pediatric populations around the world. And I also like to always talk in this setting about mass media and how we're using digital and emerging technologies. The first time I had the pleasure of going to Haiti to go to work, I was just kind of dumbfounded by how many cell phones there were and how many, everywhere you went, it was Digicel, which was kind of the nation's largest mobile phone carrier at the time. Every single person seemed to have access to information in the palm of their hand. What are we doing as healthcare workers, clinicians? What are we doing to make sure that information is good? The amount of misinformation and disinformation in the world right now is quite scary. And when we think about how are we going to act locally to have a global impact, we can take what we know. We can be the subject matter experts, to be on the panels, to be the people creating the guidelines and the barriers on what is and is not appropriate use of information and communication technology. So if nothing else, I hope through this first part of our presentation, we've been able to show you the connection and the linkage of what it is that you do every single day, what the United Nations is trying to do between all 193 member states, and how we have a space to act locally and have an influence globally. This last 2 slides for me, again, just kind of highlighting that. Think about your local actions as, yes, leading to local outcomes, of course. But if you can align it through an SDG, you can have a global impact. So whether you're doing research, you're teaching a course, or you're actually going and doing work in another country to support and build systems, think about the SDGs as a way to find partners, as a way to be able to measure your impact and your role in building towards, hopefully, the achievement of all 17 goals. My last slide here is just to show you kind of hopefully a little teaser for a coming soon discussion about if you're interested in the UN, how to get involved. There are ways to do this just as an individual. You can go through the civil society pathways, through academia, or the private sector. But that is the end of my section here. So I'm going to take a quick break and pass it over to Dr. Lovey.
Thanks everyone for being here. I'm Lovey Reynolds. I am born and raised in Chicago. I'm nursing faculty and a nurse practitioner here. A lot of my work focuses on academic research and community health. I like to put down, because we're at Lurie's today, I am a CMH, Children's Memorial Hospital alumni. So my humble beginnings as a pediatric nurse was at Children's Memorial Hospital from 2008 to 2012. And for those of you that are on virtual, thank you so much for joining us today. Today, my presentation is designed to explore how the UN SDGs intersect with the social determinants of health and how we can lead to meaningful change. Also, how local initiatives can scale to global impact. So let's start with an overview of today's my session, where we'll walk through the key themes, an exemplar, and strategies that connect the SDGs with our practice and research. So pediatric health is shaped by both global goals, which are the SDGs, and local determinants, which are the social determinants of health. Every child's outcomes are influenced by systems that link this health, education, environment, and equity. So this presentation is going to connect global frameworks to local actions, focusing on pediatric science and care. We'll explore practical team-based approaches that connect that global framework to local action. So for my presentation, we'll look at how the SDGs and the social determinants intersect to shape pediatric outcomes, and that's from prevention and access to long-term well-being. We'll also identify how physicians, nurses, educators, researchers, the rest of the healthcare team, and how they can align their daily work with SDG principles. Also, how they can use data, advocacy, and interprofessional collaboration to close those equity gaps. Finally, we'll also explore team-based local actions here in Chicago that show how everyday care, whether it's through clinical practice, community outreach, or education, and how it can drive measurable progress towards global health goals. So Art spent some time kind of talking about the SDGs. For me, the SDGs gives me this global blueprint for health and equity. And then the social determinants of health is a blueprint of what it looks like on the ground. And when we connect the two, we bridge that vision and reality. So every SDG can be seen through the lens of social determinants. So I have a few examples here. For SDG 2, zero hunger, we can talk about food security and nutrition access. SDG 4, which is quality education. Education as a social determinant of lifelong health, and SDG 3, which is good health and well-being, the ultimate outcome when all other determinants are addressed. So for us, I'm a nurse, so nurses work right at this intersection, translating global frameworks into daily action. So it's whether it be in a hospital, a classroom, or community clinic, we operationalize the SDGs through the understanding of the social determinants of health. So an example here is when we screen for food insecurities or connect a family to housing resources, we're advancing SDG 2 and SDG 11. For APPs and medical doctors, They bring their clinical experience needed to shift those healthcare systems towards prevention and equity. So advocating for equitable access to preventative and primary care addresses SDG 3 and 10. And when they partner with public health agencies to address root causes of illness, they really can integrate that social determinant screening and documentation into the clinical workflows. And then for educators ensure that every new clinician, nursing students, med students, they should understand their global role in health equity so they can also integrate SDGs and social determinant frameworks into the curricula. They can also mentor future leaders in systems thinking and community engagement. So when an example of this would be when faculty link classroom discussions on social determinants of health to SDG targets, they transform learning into global citizenship. So the SDGs gives us the why, and the social determinants of health gives us the how. And together they can create that framework for sustainable, equitable health locally and globally. So I'm just going to give a few examples of SDGs relevant to pediatric health. I just want to let everyone know that all the SDGs are relevant to families and children, but just for the sake of time, we are going to talk about a few here. These goals are not abstract targets. They are levers to address the everyday social determinants of child health. So integrating SDG reframes pediatric research from treating illness to buildable, sustainable systems that protect children's health across the generations. So I mentioned in the previous slide how nurses, APPs, and doctors and educators can integrate the SDGs into their work and practice. For researchers create that data and frameworks that validate and scale impact. So things like studying the links between social determinants, policy, and population health integrate the SDG 3 and 17. They also evaluate interventions that reduce disparity. And then lastly, provide the evidence policymakers need to invest in sustainable change. So when researchers quantify how climate change worsens asthma in low-income children, they connect SDG 13, which is climate action, directly to SDG 3, health and well-being. So to truly connect our local practice with the global agenda, we need to equip the healthcare team with both SDG literacy and social determinants of health screening skills. This means offering courses like CME courses or CE opportunities that help clinicians see how their everyday work, from patient assessments to advocacy, directly contributes to the SDGs. And finally, by collaborating across institutions, we can share resources, align curricula, and scale this impact beyond one organization or city. So global change starts with local leadership. When the healthcare team align their daily practice with the SDGs, whether through prevention, advocacy, or education, we create a ripple effect that transforms both communities and systems. So an example that I'm going to use is hunger, and that's on the next slide. I wanted to also show, I love this picture of the SDGs, it's so colorful, but for the example I'm going to use here in my presentation is the SDG 2, which is zero hunger. So zero hunger, this issue isn't about empty shelves, it's about empty systems. So in Chicago, the problem isn't food supply, it's access and affordability. Globally, climate disasters destroy crops, homes, and livelihoods. And so what connects these realities is that both local and global hunger are symptoms of the same structural vulnerabilities: poverty, inequality, and environmental instability. That's why solving hunger means transforming systems, not just donating food. So what does it mean to be food secure? This slide was from actually a presentation that I had attended a few weeks ago on what the World Bank, World Food Program, and USDA with their definition of food security. So I'll give you a minute to kind of just review that. And then we'll just go on with the 4 pillars of food security in just a bit. So our response has to go beyond food drives and donations. It's so important that we act with compassion, but this doesn't just fix the underlying system that that creates hunger. To truly address food insecurity, we need to coordinate efforts that blend policy, science, and compassion. From local shelters, clinics, or organizations here in Chicago to global coalitions working on sustainability and climate resilience. So as healthcare professionals, we often meet food insecurity as a symptom. A patient with uncontrolled diabetes because they can't afford groceries, a parent skipping meals so their children can eat. But as nurses, physicians, and researchers, we have an opportunity to engage upstream in the policies, partnerships, and innovations that determine whether families ever face those choices in the first place. So I want to just introduce the 4 pillars of food security. This is not for me. This is actually global, and it was adopted in 1996 during the World Food Summit. And I'll explain each of these in the next slide, but I thought this was a good picture of kind of like how to visualize the food security. So the 4 pillars of food security, food availability. Does food exist locally? Is there sufficient quantities of food available on a consistent basis? So is there, how's the food production? Is there crop production, livestock, fishery, wild game? In Chicago, is there healthy food access in the south and west sides? And globally, and an example of this would be the crop failures in India. For food access, if food exists, can you get it? Having the resources necessary to acquire food, nutritious food, so food prices, proximity to food, retail outlets, and farmable lands. In Chicago, the food deserts in the south and west sides, and globally, the refugee camps with the supply disruption. Food utilization, if food exists, can you get it and can you make use of it? So an individual's ability to use the food that is both available and accessible, so food safety and nutrition here. For Chicago, is there spoilage in older housing, or in globally water contamination limiting nutrition? And lastly is food stability. If food exists, do you have access to it? And you can have nutritious meals from it, and is the food consistently available? So climate change impacts stability through weather shocks and disasters. So for Chicago, seasonal instability with income and drought flood cycles in Africa are examples. So beyond the food pillars, here are a few other things that are very important about food deserts and insecurity. So agency, can you advocate for other foods, nutritious foods, or food safety? The capacity of individuals and groups to advocate about their food systems addresses inequality and power balances. Sustainability, is the system that exists robust to climate change, political and economic change? So we can directly connect the climate change and if food is available. Acceptability, is the food that is available, accessible, and usable, acceptable to our needs? So culturally appropriate produce, and is it obtained in ways that do not compromise people's dignity, self-respect, or human rights? And the last one I'm adding is scalability. Scalability is not about size, it's about the circulation of ideas. So local work informs the world and the world refines local practice. So we're moving back and forth from local to global and back. So feeding for the future, team-based calls. So we're going to talk a little bit here about food insecurity and how it connects to things like poverty and climate change. So food insecurity isn't just a symptom of poverty, it's an indicator of a system failure. In Chicago, it's transportation, wages, and access. And globally, it's climate, conflict, and policy. The solutions have to be interconnected as the problem itself. So every one of us, whether it be practice, teaching, or conducting research, has a role to play in advancing food equity locally and globally. So when we talk about food insecurity, it's tempting to imagine that the solution is simply just giving food to people, but just remember that it's far more complex than that. Food insecurity is not caused by a single shortage of food. It's the result of structural inequities. So in Chicago, for example, there's no shortage of calories. What's missing is the access to affordable, nutritious options. So family and food deserts may live surrounded by fast food, but without a single grocery store for miles. And globally, the same patterns repeat. In many parts of the world, food exists, but cannot reach people because of climate disasters, political instability, and broken supply chains. So remember, this means the problem isn't just lack of food, it's lack of stability, equity, and infrastructure. So the next few slides at the table may be hard to see, but this kind of connects the healthcare team with nurses, physicians, APPs, researchers, social workers, and public health professions. And what's some things that we can do locally and globally? So I'll give you a minute or so to kind of review that. Next slide is interdisciplinary partners. So this is beyond healthcare. So just remember that food insecurity doesn't just belong to one profession. It's an ecosystem issue. And, it's nice to kind of collaborate and work with others so that we can and contribute our work to help local and global needs. So just a few things that I wanted to, and this is just connect Chicago actions for connecting the SDGs. So by integrating SDG principles into local healthcare, education, and community partnership, Chicago becomes a living exemplar for global change. And that's by proving that local leadership drives worldwide progress. So some things to think about is for SDG 2, we can partner with the Greater Chicago Food Depository, and that's the screen, food insecurity. For SDG 4, we can work with Chicago Public Schools on Child Health or Family Health Literacy Days, and that addresses SDG 4. And then join Chicago Department of Public Health Climate and Health Program for heat wave preparedness. And lastly, the Safe Communities SDG 16 enable food access and distribution. So things like violence, political instability, and unsafe neighborhoods, they really limit people's ability to buy, transport, or grow food. Also, neighborhood violence can deter grocery stores, food trucks, or community markets from operating, so reinforcing that food desert. So safety is infrastructure for nutrition equity. And Art, do we have time for just a quick exemplar? I found this awesome article online when I was working on this presentation, and it's called the Kidscope. And the Kidscope model is from Cork, Ireland. It shows how nursing leadership transforms community-based care into the scalable framework, and that's for achieving the SDGs. And I'm happy to share that article with you if you'd like. So some findings from that framework from Ireland. The findings, so the first one was nurses as system integrators. The KidScope model positions that public health nurses, which they used in this study as central connectors between healthcare, education, and social service. Their coordination role transformed fragmented community resources into a unified unified early childhood system. That's a scalable blueprint for nurse-led integration worldwide. The second finding was the early intervention as equity in action. So by focusing on early developmental screening and family-centered referrals, KidScope demonstrated that health equity begins before illness emerges. And these early years approach exemplifies how preventative nursing interventions advance SDG 3 and SDG 10. The third finding was education was embedded in practice. So the partnership between nurses and educators and doctors showed how clinical spaces can become learning ecosystems. Families received real-time health education, and nurses gained continuous interprofessional learning. And that fulfilled on both ends SDG 4, which was quality education. The fourth was interagency collaboration as an engine of sustainability. Sustainability is really important for any initiative or project. For KidScope, the success depended on shared leadership, communication, and mutual accountability across sectors. This collaboration created a self-sustaining model that can be adapted in other urban settings, such as Chicago, where siloed systems often limited community access and outcomes. And lastly, the local innovation with global resonance. Although grounded in an Irish community, KidScope reflects a universal truth that local healthcare leadership can drive global health goals. By applying these principles, interprofessional collaboration, early prevention, healthcare team coordination, the healthcare team everywhere can move from isolated care to integrated equity. So that's an example from local action to global alignment. So integrating nursing, medicine, and social systems really demonstrated how interprofessional collaboration drives global health equity. When the healthcare team works together, so for nurses identifying social barriers, physicians addressing clinical needs, educators promoting health literacy, social work connecting family to resources, we really create a continuum of care that extends beyond the clinic wall. Each coordinated local action strengthened the social infrastructure that supported their SDGs. And we're already doing that here in Chicago. We're already doing so much work locally in our hospitals, our schools, and community. But the next step is that scalability globally. So by aligning our local models with the SDG, sharing best practices across borders, building international partnerships, we can turn every collaboration into a global movement for health equity. So what we can learn applying that KidScope framework, and I'm just going to kind of go through these a little bit fairly quickly, but they are also important. The first one was building an interagency pediatric network. So for us in Chicago, partnering with local pediatric clinics, schools, public health agencies to create an early childhood referral and assessment pathway. And this is similar, I would say, to the KidScope model of collaboration between the healthcare team. Another thing we can do is integrate early childhood screening. So embed developmental and social determinant of health screening tools into community health fairs or student projects. And there's many screening tools out there. I actually found a pretty good table of all the different types of screening tools. I can also include that if anyone's interested. The third is, I put nursing students here, but actually any students, healthcare students as connectors. So adapt the KidScope model for nursing, APPs, medical education to train students to serve as care coordinators. The ones that bridge that family, community, agency, and schools, aligning with SDG 3, which is health, SDG 4, quality education, and SDG 10, reduced inequalities. Number 4, so create that data to action feedback loop, and that's very important too, to collect outcome data from screenings and referrals to identify those local gap services. So things like food insecurity, developmental delays, housing, and sharing these findings with city, state agencies, and partners to inform that policy advocacy and curriculum redesign. 5th, develop a faculty-led pilot, something like KidScope Chicago. We can launch a small-scale pilot in partnership with local early childhood centers, and that can be coordinated by the healthcare team and document the process along the way, and create that research project to be able to share that data back into the communities. Lastly, scale through education and policy. So integrate findings into models, frameworks that are used here in Chicago. Apply SDG integration into teaching and research and practice. And lastly, just some reflection, which of the SDGs connect most closely with your daily work? And what's one local action you can make this month to advance it? So I just want to move to the SDGs, and because I love that picture. There you go. To kind of reflect which of these, and just, we don't need to pick all of them to address in our practice, but maybe 1 or 2 that you're doing already, and then you can scale up. So thank you so much, and thank you, Art, for inviting me to be here.
Thank you very much. I know we are just at the coming up on time here, so I want to say thank you so much for joining us this afternoon. Please do use the chat feature if you have a question that you'd like to speak about. You also received my email address when you got the link to this presentation. We'll send out our slides as well as a recording of our session today. So as we kind of kicked off our day today together, I hope this was the beginning of seeing the connection between what we do, what we ask you to do in your day-to-day, and how you're having a global effect. You are making a difference, and through things like the SDGs and the United Nations, your impact can grow and amplify. So thank you so much for joining us today. We will end it there, but please do reach out with your questions, and we look forward to seeing you for our next presentation. Thank you.